So I've got some questions from the field, which I know is something that's been of interest for you for a while. So if
Yeah,
you're ready, we can kind of hit them up rapid fire.
let's do it. But I may invoke my constitutional rights and refuse to answer at some point. You never know.
That's fair.
All right, let's go for it.
So have you ever been stumped when you, I mean, that's just what it says, but my presumption is, have you ever been stumped when you get called medical control?
I won't say I've ever been stumped. There have been times that I didn't feel like I had enough information to answer the question. And I would say a lot of times those center around a consent and capacity question. Like, hey, this patient's altered, but they're alert and oriented. They need to go to the hospital, but they can't. And I just feel like I can't get enough information from the medic to help them make a valid decision as to whether they need to go to the hospital or not. But as far as like, stumped, like, hey, this person is exhibiting XYZ and I don't know what to do, I've never really seen that in the field because or in questions from the field because again it boils down to BLS care and ABCs. I mean, we're not going to operate in the field and we're not going to have fancy medicines in the field. We just need to keep them stable till they get to the hospital. So, and I think sometimes medics forget that we're not going to cure someone in most instances, maybe anaphylaxis or something like that. We're not going to cure someone in the back of the ambulance. Our goal is to just get them to the hospital safely so that we can do all the fancy stuff at the hospital.
Like fasciotomies and chest tubes?
Yeah, finger thoracostomies. Yeah, we get to do those in the hospital. Yeah.
How often would you say you actually get to do those out of every, like one out of 10,000 patients?
Oh, I mean, I put in a fair amount of chest tubes, I would say. But finger thoracostomies, really, I would say I've probably only done one or two of those ever, but I've done maybe a handful of cracking someone's chest in the ER, which would be kind of the field equivalent would be the finger thoracostomy. I do think that probably in the future, with special training, we may ultimately move to that because there's some good literature that shows in a traumatic cardiac arrest, finger thoracostomies can be beneficial. So who knows, maybe.
Well, and I did get a question in here and I had kind of scrubbed it out, but there was one about whether or not we would see finger thoracostomy in the field anytime soon. And I thought, well, that's kind of a revolving question. So it's funny that we have addressed it this early when I put it out. But and it revolved around that and medics being unable to appropriately um, find the landmark for needle decompression
Yes.
100% of the time, which is
Yeah.
that's not just an Oklahoma issue though. I mean, that's a nationwide
Yeah.
issue. Every time you pull up some literature, you see where they stick it mid-sternal, and you're like, what's
Right.
going on?
Well, and I think that's why there's some good literature that supports obviously doing lateral needle decompressions. And there's actually, I'm not going to make this a marketing video, but there's Sam Medical sells a device that's a little card essentially. And I don't know that I have an example of a card on my desk, but a little card that goes in the axilla and gives you a nice little window of where to do that needle decompression. Because I think medics are a lot of times afraid they're going to go too high when they do a lateral needle decompression, and it's actually the opposite. Most medics go way too low. Because surprisingly, the liver and the spleen and all the innards from the abdomen can be way higher in the chest than you think. So I think again, lateral needle decompression, finger thoracostomy, all of those kind of random trauma resuscitation things would require a fair amount of training above and beyond what any medic gets in any program today, even to include cadaver labs. We'd have to do cadaver lab training to show the landmarks and stuff.
Well, and it's probably something they could incorporate, not cadaver labs, but they could incorporate a little bit better education initially and upfront. RSI was something that I believe there was one paragraph in my paramedic program, and it's something we talk about very extensively in practice.
Well, and anatomy. I mean, with virtual reality and all the stuff that's online these days, anatomy and physiology could be hit a lot harder because I think that's also one of the places I feel like a lot of medics are lacking is basic anatomy and basic physiology. Because, I mean, it's one thing to know that if I give adenosine, it slows the heart rate down, but physiologically, why does that work? You know, if I do a finger thoracostomy too low, what organs am I going to hit? You know, so I think just hitting anatomy and physiology a little harder would work too.
So, and that kind of segues into our next couple of questions. Um, from your experience, where do you think that medics educations lack? I'm going to reword that. In your opinion, where is it that you think that medics could strengthen their education foothold in the
So
realm of pre?
I'll get on my soapbox about education in general and not just medics, but I feel like all of the educational programs, medic, nursing, to some extent doctors, etc., we teach to pass the test. We don't teach to take care of patients, and we don't teach critical thinking skills. You know, so I mean, just as an example, just the other day we were talking about the EMT skill sheets as an example. And so you probably remember when you took your first EMT class, you had 8 or 10 of those skill sheets and you had those suckers memorized from top to bottom. If I threw you in a room with a BVM, by God, you knew BSI, scene safe, and how to operate a BVM. But if I put you in a room with a patient that was having respiratory distress, you didn't have a check sheet for that. So I feel like, and we're finally moving away from that with National Registry to some extent into doing scenario-based skills testing because you don't roll up on a scene and find a patient that says, "Hey, I need a BVM. The scene is safe. Can you treat me?" You roll up on a scene where a patient's not breathing well, and you got to figure out, okay, why are they not breathing well, and how do I treat this? And so I think we need to move to more, I don't know the right word, system-based approach teaching, you know, scenario-based, so that medics can put it all together. Because the educational world with this, have created a whole bunch of medics that were skill sheet based. And if you take the patient out of the skill sheet, they can't function very well. So, I mean, I think that's where our education is lacking is we need to teach how do you put all this together.
Yeah, I mean, I took mine in 2012, and I still remember it's BSI, scene safe, number of patients, mechanism of injury, consider ALS and C-spine. And that's if you say those first few things
Get eight
before
or
you,
10 points, or who knows, what is it, right?
yeah, I mean, you get almost, all your critical fails. So
Yeah.
you're absolutely right. So to piggyback on that one of the questions was how often do you think that medics should be training, and if they do research and continuing education on their own, what sources can they trust and not trust?
So, how often should medics be doing continuing education? I would say every day. You should learn something every day. I mean, obviously, a lot of people know that I still work with the residency program here in Oklahoma City where I train. And I frequently will tell the residents, you should learn something on every single case. It may be the 20th snotty nose that you've seen in the fall from a kid from the daycare, but there's something to learn on every single case. And so if you are not trying to figure out something on every patient that you didn't know, no matter how simple it was, maybe you forgot the dose of, I don't know, you forgot the dose of Levophed. Look it up. Maybe you didn't even use it on this patient, but the patient was a little hypotensive and you thought you were going to go look that up. Learn something on every single case. Now, that may not be continuing education per se, but it is. You know, I think, again, a lot of times we think about continuing education as I got to get my nice little certificate to scan and upload to the National Registry. And that's true. You got to get so many hours. That's a thing. But you also need to just continue your education. You know, things change. Things are different today than they were 5 years ago, and they're going to be different 5 years from now. So you've got to stay up on that. As far as where to get that, I mean, as crazy as it sounds, there are a million TikTok, YouTube, Instagram. I'm not saying they're all good or that they're all accurate or that they're all whatever, but that's up to you, the listener. You know, listen to those videos and then do some Google searches. Get on Chat GPT and ask it, is this right? Ask your partner, you know, is this something that sounds legit? I mean, because there's good stuff and there's bad stuff, and there's also people that put tricks out there of how to do things. So I mean, as crazy as it is in the world that we live in today, a lot of those social media learning platforms are very good and they're quick because that's the other thing people want today is they don't want to sit down in front of an hour-long video with a bunch of PowerPoint slides. They want a 90-second video that says, here's how you memorize ABC.
Yeah, and I mean, that's the world we're living in. Give me everything fast. If you look at YouTube, they've got
Oh,
YouTube,
absolutely. Yeah.
you know. And that kind of answered one of our other questions, but if you want to expand on it, I don't know. But it says, how does he feel about medics using social media for education and community outreach? I think we
Yeah,
kind of.
again, you just got to verify it. Verify the content. That's the main thing.
So we've got quite a few about med control calls. I'm going to save them for the end.
Okay. Well,
But
we can't go too long, man. We got to make these videos short. We just said people like 90-second videos, and here we are. I don't even know. I was looking since we did record. I don't know how long
a
we've been
minute.
going.
What sets a good medic apart? I don't apart from what I'm not sure. Like maybe a not good medic I guess
So
I
I can kind of answer that with like a multitude of answers, sort of, but critical thinking. The medic that calls and says, "Hey, I think this person has Sushu Magushu fever, and here's why I think they have this, and I would like to do this, which is outside of protocol, but I think it will treat that." That tells me that this medic is thinking about what's going on physiologically, what's happening, and how this particular medicine is going to work to take care of that. So I think critical thinking is one thing that sets a bunch of medics apart. The other thing that I would say that maybe I don't know if sets a medic apart from another medic is continuing education. You can a lot of times tell a medic that is continuing to learn stuff versus the one that says, "Well, we used to," or "back in the day," or whatever. So I think those are probably two of the biggest that makes a good medic a great medic.
Hmm. And that answered one of our other questions.
See, I'm just whipping through these.
Uh, so how can field providers strengthen their relationship between the medical director and street crews?
So I think one thing is, and I never mind these calls, and I'm sure Dr. Wells doesn't, is a quick text message after a call that says, "Hey, I want to go over a call with you. Call when you can." Because then we get to kind of debrief that and talk about what'd you do good, what'd you do bad, why did you think this, why did you not think this, and so that back to two or three questions ago, that's continuing education. You're not going to get a little fancy certificate for talking to the medical director, but you know what? If you call and go over that particular call, you're probably going to learn something. And you're probably going to think about, oh, I should have done this, or maybe I should have thought about this. And so that's always open. I'm not saying we want to get 6,000 calls a day, don't get me wrong. But if there's a call that's interesting, or you didn't understand, or anything along those lines, either of us are always glad to debrief that call with you and talk about it for sure.
Why don't ambulances just go to the hospital? Why do they sit on scene?
So, I think we all hear that a lot of times, especially you'll see family members peeking in the back window trying to see what you're doing. And that's because there's things we can do on the scene, obviously. I mean, everybody should understand that there are things we can do. I mean, especially when it comes to airway breathing circulation. And that's why there obviously was the big push years ago for field termination. I don't have a fancy magic wand at the hospital that I get to wave and do something different with cardiac arrest than you've done in the field. I mean, the ambulances carry all the same medicines we have at the hospital for the most part. They have all the same airway equipment. We have video laryngoscopy in the ambulances now. So there's all of these things that we have in the back of the ambulance. And so it really is an emergency room these days. We mostly understand that, but it's our job to explain that to families as well. And that's, not to go to another question if it's there. That's another thing I don't think medics do often enough. Like when I'm out doing an on-scene observation, as medics don't tell the family, "Hey, we're gonna put them in the back of the ambulance, and we're gonna be here a little bit. Don't worry, we're just gonna start some IVs and get them hooked to the monitors and give them some medicines and do those things," because a lot of families truly think that is just a big taxi with lights and sirens on it, and they just want you to drive real fast to the hospital. So I think we as field medics need to do a better job of explaining to families what we're doing, why we're doing it, et cetera, which goes back to a previous question of in the paramedic programs, they teach us to pass the test. They don't teach us to talk to patients and talk to families well enough. There, how's that a long-winded answer?
That was a very long-winded answer.
Yes.
So, but appropriate for sure. But you brought up uh, on-scene observations, and that's our last question before our med control calls answer questions, whatever they are.
Yeah, all right.
When conducting an on-scene observation, have you ever came across a situation that could have been dangerous for a patient and had to intervene immediately? How would you go?
Now, I've never seen one that's dangerous, or obviously I would intervene. I mean, like, I think people know, and I tell them when we're doing our new agency orientation that myself, Dr. Wells, anybody from the OMD may show up, and we're just there to watch and help. I mean, and that's truly what I do. I think you could ask most of the medics that I've been on an OSO with, they'll just see me kind of listening, maybe jump in and ask a question here or there. And as if I get there first, which is my goal on every on-scene observation, is to show up before the ambulance and fire truck just to prove that I can do it. I immediately transfer care to the medics. I mean, I tell them what I've heard, and then I step back. And a lot of times I go out and pick up the gurney and bring it back in for them or something like that. But if, I mean, I can't even think of an example. If I were to see or hear something that I thought were detrimental, I would immediately step in. I mean, that's why you're there, is to help prevent that kind of stuff, obviously, and to form a QA. And the other thing that I think a lot of the medics will tell you is that as soon as that call ends or is over, I'll quickly debrief. I mean, it's easier with the fire department first responders because the ambulance is taking off and transporting. But I'll say to the fire guys, hey, good job. This was an ultramental status. You checked their blood sugar right away. Good job. Or, hey, you forgot to check their blood sugar right away on an altered mental status. You need to do that. Just something to say, hey, here's what I noticed. Let's get better next time. Or you did a great job this time. Keep doing it.
Yeah. And I always used to forget blood sugars until it bit me in the butt once. Uh,
Yep.
I don't do that
Can't
now.
say that hadn't happened to me one time in the ER as well. So, hey.
So final five, they're going to be rapid fire for med control calls. So
Okay,
uh,
so I got to be short-winded here. That's what you're
let's
telling me.
squeeze them in.
All right.
How do you view paramedic discretion within your SOPs? Where's the line between following protocol and using good judgment?
So I'll answer this with an answer that is politically correct and can't be answered. I don't think we should have protocols. I think we should have guidelines. But that goes back to the schools. We got to teach medics to critically think. Right now we have flow charts because that's what we teach. But I think we should just have guidelines, much like your ACLS guidelines. Patients don't read the textbook when they get sick. So medics need to critically think and treat the patient, not the monitor or the protocol. Next question.
I think you kind of answered this earlier, but how does doc feel when somebody calls med control and they already have a treatment plan for the patient? You feel great.
Yeah, and I think go back to the first video we did about contacting med control. I want a medic to call and say, hey, I'd like to give whatever. Here's why I would like to do that. I want to know what you want and then why you want to do it. And then we're going to answer it.
I want
Easy.
to give PXA for this angioedema.
Absolutely. Let's try it.
How can we paint a better picture of him since he's not, or for him since he's not present?
I mean, a good history and physical. I mean, I have to know what's going on. Much like I frequently say when I read a medic's narrative, I need to be able to read that narrative and picture that patient in my head so that I can understand what's going on. Same thing if you call and want to give TXA for angioedema. I need to know, okay, one, you've considered angioedema as the cause of this. How sick is this patient? What's going on? So you have to be able to paint that picture for me over the phone. And maybe that's going to change in the future with technology. Maybe we switch to video. I don't know. I mean, that's certainly a possibility with some of the new platforms we're looking at, is maybe we switch to video calls and then I can actually see the patient and talk to the patient as well. Who
You
knows where that's going to go?
could walk me through a crike.
Absolutely. Or a finger thoracostomy, right? Here's your knife. Here's your finger. Let's do it, right?
So what's the craziest call that you've got for med control? Um, the submitter said, I feel like we've called for everything from BS to OS.
It's like that when somebody finds out you're an emergency room doctor and they say, "What's the craziest thing you've seen?" Well, I don't know because crazy to me and crazy to you are two different things, and so
And I've
I
already
don't
forgot about it when I get home.
do what?
And I've already forgot about it when I get home.
Yeah, yeah. I mean, so I can't just sitting here. I can't even tell you what I think the craziest med control call would be. I mean, I really can't because they're so variable and we get so many that I don't know.
And oftentimes, memorable calls have nothing to do with the actual patient. It's like all the other things that are going on at scene,
Yeah,
right? Like
absolutely.
there's a house fire secondary to an explosion that was caused by a tornado.
Yes.
Yet I've got grandma that's having an asthma attack.
Right.
Call's crazy because of all that, not because of
Yes.
the attack that I see all day.
Right. Absolutely.
Final question.
Final question.
What
Make
goes
it a
through
good
your
one.
head when a medic from the field calls with the most bizarre situation and you are kind of stunned on what to do? I don't, I mean, we kind of answered being
Yeah.
stunned, but like what goes through your head when you're presented with a very, just a weird situation? I don't know. Somebody swallowed a goldfish.
Yeah.
You
I don't. I mean,
know,
that's kind of like what's the weirdest call you've seen? I don't know. I mean, that's one of those that it's hard to answer a question about until you hear the scenario,
sure.
because I mean, I mean, I have heard some strange things on medical control calls, but I can't off the top of my head remember any now. But again, kind of back a couple questions. The medics got to paint a picture. They've got to really let me know what's happening, why it's happening, how it's going on, and then what they want to do. Just to call and tell me a crazy story, well, still, it just goes back to BLS. I mean, maintain their airway, maintain their vital signs, drive them to the hospital, keep them alive till you get there, that kind of thing. We don't always have to do something in the back of the ambulance. Sometimes we do, but we don't always have to do things.
You know,
So,
well, I got this at 20 minutes.
okay, that's pretty good, right?
Yeah, I think
Considering our
we've,
first one was 45 or 50. And we'll blurb out that little part where I have my little freak out about the where we actually recording this.
yeah, for sure.
So, okay. Well, hey, Jayton, as always, a pleasure to see you. Freshly shaved head, nicely trimmed beard, the
Yeah.
amazing shirt all the time.
Yeah.
Yeah,
This is my dedicated podcast shirt.
dedicated podcast shirt. Okay, we'll do another one of these soon. Thank you, guys.